So good morning, everybody. I have to tell you that trying to estimate the audience is probably one of the most important things I try to do when I speak. And this morning at 5:30 a.m. I had a crisis of, oh my gosh, am I giving the right talk? And so I actually brought two talks. So this is one of them. And so you say the Chancellor's research breakfast, and then you say, oh, but it's people from the university and the community. So I should tell you that my research career has been largely solving problems that are in my everyday life. And that ranges from a study that I accidentally did with Deidre Buchwald, who is here now in population health, also made the leap across the state, looking at email communication with patients and doctors. And that was in the 1990s when I was just starting out and I had two young children. And I was senior enough to want to be mentoring a junior person, and I was, who is also in this city now, Matt Holland, and I was junior enough to not know how to fund and run a really big research study. So I found Deidre and I said, look, I need your help to do this. And we published what was one of the first studies across Washington State. We surveyed all the doctors in the state through the WSMA, and published that paper. But that was me without having a PhD or anything. And in Australia, I worked in an Aboriginal clinic for 9 years, and there was an 18-year life expectancy gap in Australia between white European immigrants and the original Aboriginal population. And I was working in this clinic, and I was taking care of a lot of patients with diabetes, and I said, what can I do? And I had this woman patient who had a BMI of about 45, and if you don't know what that means, that's categorized as severely obese. She was on morphine pain medications for back pain, shoulder pain, knee pain, hip pain. She was on antidepressants. She was on every medicine we could think of, and she was on over 100 units of insulin, which is a lot. And there was this new surgery at the time called laparoscopic banding, and this had just started in the early 2000s. And I happened through a colleague connection to run into a surgeon who was the head of the research center in Melbourne, which was 2 hours away. So I tried to refer this patient. They said, well, there's a 5-year waiting list. I'm like, oh, gee. And they said, and then those Aboriginal patients, they never come. Well, I'm thinking, well, it's a 5-hour round trip, right? You're a dark-skinned person. You're dealing with all sorts of cultural safety issues. And how can you possibly be expected to drive 5 hours threatening your job, right? Because you don't have that many days off every 2 weeks for a post-op check that's 10 minutes long, right? I mean, think about that. The cost of gasoline, you can't go to work, you have to make alternative arrangements for childcare, all that stuff. So what I ended up doing, I had never done a big randomized controlled, nationally funded research trial. But I said to this surgeon, hey, I have all these people who deserve an opportunity to get to this place. So what if we brought the surgery up here to the bush, as they call it in Australia? We weren't in the outback, but we were in the bush. And guess what? We got funded for about $500,000. And at the end of the study, all of those Aboriginal patients who have almost no education, there was a 10% high school graduation level in the town when we started. Everybody had the same results as the highly educated inner city populations. So that's just to give you an idea. I don't have all that much research training, although I've gotten a lot through experience over the years. But the story of all the letters was completely accidental. And 15 years ago, if somebody had said, right, you're going to end up being an associate dean in Australia, I would have said, I'm sorry, you need to go see a psychiatrist. So the letters aren't about bragging, they're actually about a bit of torture. Okay, so the first lesson I learned is, I'm in medical education, right? And I grew up thinking the North American system was obviously the best, and the US was obviously the best place to live on the planet with the best health care, yada, yada, yada. So what I learned, though, when I went to Australia, they said, well, why should we give you a degree? Your training is X years shorter. And actually, I added it all up, and I've spent a lot of time doing this now. Education, no matter where you are in the world to become a doctor, is about the same. It's about 12 years. From starting your education to being an independent practitioner. But there's a yo-yo there, but it's not a big one. So now 3 countries agree that I am qualified to practice medicine. So I have an MD, I have a master's from the American College, I have a fellowship from the Royal College of Australia, and I have an academic fellowship from the Royal College of Canada, who decided to rescind it when I stopped paying my dues this year. I'm like, okay, am I qualified or not? But anyway, what I learned from all this is paperwork and dollars. And we're in a health shortage environment, right? So why am I spending 2.5 years of my life that I have spent applying for clinical privileges? I'm still waiting for my Washington State final numbers and all of those things. But that is a huge waste, right? And we're in an increasingly mobile healthcare workforce situation. And I learned a few weeks ago that there is now a pact between some of the Western states, Washington is not part of it yet, to allow license changes for doctors across state lines. That's a really important thing. And you know what? If you Google me in Idaho or in Wyoming or in Washington or in Australia, I still have the same qualifications. So who gets to decide? Anyway, it was pretty interesting doing that. So if it takes that 12 years, our current problem is that 50% of US medical students meet criteria for burnout at entry to medical school, right? So half of students, and I said to myself, well, why is that? And the woman who's doing this research is a woman named Lottie Derby, who was my resident at the University of Washington, and she's now the world expert in this. And so she and I had a conversation. I'm like, well, you know, we put them in this pressure cooker of pre-medical education, and they are fighting and fighting and fighting to get everything they can on their CV, from straight A's in school to, you know, oh, I went and volunteered in Africa, to, you know, service learning in the community, serving in a soup line. So when I went to Australia, I suddenly had these kids who started medical school at 18. Now, there are obvious cultural differences between Australians and Americans, but these students were pretty darn happy. And not only that, at first I thought, oh, they are so young. They are never going to be mature enough to deal with patients. But guess what? They all grow up. And most of them were actually completely fine. So I was shocked. And then I thought, I had a few come to my office who were saying, well, I don't really want to be a doctor, but when I got my grades from my exams, my parents said, oh, you should be a doctor. We would be so proud. We've never had a doctor in the family. And the student is now in my office 4 years later going, well, I really wanted to be an accountant, but my parents wouldn't let me. So I'm going, okay, so we should be having them do the American model for career choice. But it turns out that's also an issue. So some students from the University of Rochester in New York State wanted to spend the summer in Australia. Who wouldn't? And they came to me and they said, well, we want to do a study with you. And I said, well, I have this problem, which is now I'm questioning whether the North American model is better or the Australian model is better. I think the North American model is better, but these students are so happy. So we did a study of over 600 medical students in entry after high school versus entry after college in Australia. And the students who entered after high school were slightly less sure of their career choice. Okay, that fits. But they had equal or better self-reported coping with their course, preserved empathy, lower burnout, and less alcohol misuse. I was shocked. But this is the power of research, right? So now I'm going, well, what do I do with this? You know, so we published it this year in medical education with these students who now all have this on their resume to get better residencies, right? But my conclusion is actually there are only a few medical schools in the US who are doing this, but Dr. Derby's research and others confirms that if you don't have to worry about getting straight A's and competing with everybody else, you actually do just as well and you're not as likely to commit suicide. I mean, this is a serious problem, right? Doctors, burnout, suicide. So as we start a new medical school, we're going to do the traditional North American model, but we are going to try to innovate in this space. And I think the dean and I would both have the question of how far can we push this? How much regulatory paperwork do we have to break through and so on? But I do think we need to be looking at these things and going, well, just because we've always done it that way, if we can have the research that proves the other and saves students money, you know, we should think about that. So area for WSU to become potentially a national leader in. Okay, so the next thing, you get through all that stuff, medical school, residency and everything, and then what did I learn about being a doctor? Okay, so I'm practicing in 3 countries, and I loved practicing in Australia. I liked practicing in Canada, and I am dreading practicing again in the US. You ask why. So 54% of US physicians experience burnout, and that's an increase from 46% in 2011. Well, you know, we're over half now. So no matter what you do, you don't want to go in and you don't want to see a grumpy doctor. You don't want to have your doctor on alcohol or drugs. You don't want to have your doctor depressed and commit suicide. And some of my colleagues have committed suicide, and it really, you just go, oh my goodness. So residents now spend more time on computers than with patients. That's not a huge surprise for any of us who are in medicine, but for the rest of you, you know, you go into medicine because you want to help people, right? You don't go into it because you want to sit typing stuff all day at a computer. And so in 4 ambulatory specialties, this is a study that just came out this year, doctors spent 27% of their time in direct clinical face-to-face time with patients. But in every visit, and you've probably had this experience, in the exam room, they spend 53% of their face time, only 53% in FaceTime, and 37% of that time on the electronic health record. So they're spending more than half of their time, even when they're in a room with you, dealing with the computer stuff. So 49% of the time on, 49% of the rest of their time on electronic health record and documentation review. And then most doctors, and I have validated this in Spokane with the medical director from Sacred Heart, 1 to 2 hours of personal time at home doing documentation. So we can now track, you know, when doctors are doing their documentation. They're doing it at 9 or 10 at night and at 5 or 6 in the morning. And I used to do this in Seattle even before I left for Australia in 2003. So overall, non-patient related paperwork, meaning just justifying things to an insurance company, is 16 to 20%, so a day of doctor's time every week, and drives doctor dissatisfaction. Okay, oops. So the doctor of the future, we can help define it. So this is the dean's question that he asks. So what will the doctor of the future look like? Well, it's not going to be Marcus Welby, MD, for any of you who remember. And if you don't, I'm really sorry. I'll tell you about it later. But the idea that you go there, you comfort people, you take care of people, you're the family friend, the confidant. So practicing in Australia was a much better match for my skills and training. I trained at UW in primary care, but I spent over half of my time in that residency working in the intensive care unit, the bone marrow transplant unit, and doing complex consults, working in the Harborview hospital, emergency room, etc. So I come out, right, I'm a primary care doctor. Okay, so I don't need a 1.5 years of ICU training to be a primary care doctor. On the other hand, I don't maybe need a 1.5 years of primary care medicine to be a hospitalist. Experience is always good, but in a situation of limited time and money, we have to rethink this. So only 25% of US physicians work at the top of their license 75% of the time. So that means the rest of the time you're doing things that are just kind of there and not stimulating, and somebody else could probably do it. Compared with only 38 to 51% of other health staff. So other health staff are also doing stuff that they are overtrained to do. So one of my students who then came in Australia, who was from Botswana, came to Australia for medical school because they didn't have a medical school, then went to Harvard and Penn to get his training. And he said, I'm sitting here prescribing first-line blood pressure medications, and I should be doing more complicated things. And I completely agree with that. He's now one of the leaders at the new Botswana Medical School. All right, you've probably seen something like this. So now that we've said the US doctors are wasting all their time doing this, and the staff and teams that work with them are also wasting a lot of time, we can see that Australia, and the Canadian flag is right under the Australian flag. You can see that the US spends, oops, I'm pointing at the computer and I should be pointing up there. The US spends a lot more money and gets a lot worse outcomes. So the bar on the left is life expectancy. And you could argue that 3 or 4 years is not a big difference, but with the crisis of obesity in the US, we are estimating that the average life expectancy may decrease by 10 years in the next couple of decades. 10 years. So we will be down to 67 or 68 as the average life expectancy. So this is a big deal. I'm not going to ask what you ate for breakfast. So you look at all this stuff and you say, why would I choose this career or that career? And our medical school is aiming to engage students who will take care of people wherever they are through telemedicine, et cetera. And in my first study, when I was a chief resident, I said, well, I'm a chief resident, I should do some research. So I looked at the career choices of everybody who had gone through the University of Washington primary care track for the last 10 years. It was about 100 doctors. We had 98% response rate, mostly because I called each and every one of them and said, you're an alum, I need your opinion here. And everybody in that group, about 40% of them had gone on to specialize, and everybody said specialization is easier. The generalists all said specialization is boring, which was really interesting. So at this point, things are even worse than that. And a lot of that is the payment structure and the recognition structure and this this electronic health record stuff. So what did I love about practicing in Australia? I'm an N of one, right? I'm me. I still have my practice style. I've been trained here to do all the wonderful things that we do in Washington State as doctors. In Australia, they had universal coverage. And before I started practicing there, I thought, oh, waiting lines, I won't be able to get what my patients need, and so on. Not true. Now, I paid a higher tax rate there, right? Everybody does. But we get free health care with a few exceptions. There's a national formulary and prescription coverage. So this is like the VA, right? If it's there, I can prescribe it. If it's not, I can't, or the patient has to pay for it. But only once in 9 years did I need a medication that I couldn't get for a patient. And I went to the medical director and I said, look, this guy's ending up in the emergency room every month. I suggest we buy this medication for him. We did. He never turned up in the emergency department again. Now, systems like Kaiser can do this. Maybe the VA can do this, I don't know. But we have an opportunity here at WSU and in Spokane and across the state to look at doing some, experiments where we take half the doctors at a particular hospital and say, right, you're going to use this formulary and we're not going to charge you. We're going to track the costs outside. We're not going to make you do all this documentation just for billing. And just see, in a year, who's more burnt out, who's taking care of more patients, because I could see 40% more patients without even blinking and had more fun, and I was done with my dictations at 5:30. The nurses would turn out the lights at 5:02. So all the patients had to be out of there, and they were. And I was seeing 40% more patients every single half day. Okay, so what else was different? Well, their general internists are consults only and don't do primary care. I thought I would miss that, but you know what? It's all good. I was working more at the top of my license. Documentation was for care, so all of my notes only had exactly what I needed to know and my colleagues needed to know to take care of the patient. Billing was simple, new or review. And then right before I left, they added an extended new or review. I'm like, no, don't do it. Because you go, well, I should be paid more fairly. But all the time that you spend making those little decisions and documenting it so it can be an extended one, it sucks up the time that you say, So, and the other big thing was that I did not need to repeat student and resident documentation. So for those of you who aren't in healthcare, every time a student or resident sees a patient, the doctor has to see the patient, unless it's a senior resident. The doctor also has to basically rewrite the whole note. Why, I ask you? And I don't think, if you look back at those mortality statistics, obviously people weren't dying in Australia because I wasn't double documenting, right? So there are some differences, but overall, I think those three things explained a huge amount of the variance in A, my happiness and less burnout, and B, in some of the costs of care. Because you can just be 40% more efficient. So we have this really expensive system where it costs a lot to train doctors. So if you go to Harvard, you come out and you have a $360,000 debt. If you go to WSU, we estimate with our first class, after 4 years, they may have only 200,000, only 200,000. So what about the cost of what we do in medicine in the US? Is that the cost? So at age 65, there's a spend of $300,000 for a patient who lives to 80. That's our average cost. So when you think about that, that's about the cost of a house in Spokane. And if you have chronic conditions, diabetes, heart disease, and so on, we estimate that it will cost $450,000 per person to take care of them to age 80. The big costs are hospital care, medical services, medications, and nursing home and hospice. And resident salaries do not explain this. They're not actually that high, $53,000 to $57,000. And primary care residents are at the lower end of that. And we're trying to get primary care folks, right? And doctors' salaries, estimates are $168,000 to $220,000. Now, if you think about how long it's going to take you to pay back a $360,000 debt, even with that, with interest, what is it these days, 8% interest or something? It's not small. So why should we be pushing this? Well, there's a great experiment in Portugal where, it wasn't an experiment, but they introduced a national health coverage, so like Australia. It was funded by taxation, and they had some private input and co-pays, and Australia does have some. Prescriptions cost $30 a prescription unless you are low income, and then they're either $5 or free if you're Aboriginal. And they introduced a primary care system with general practitioners and nurses, and life expectancy improved by 9.2 years over 30 years, just by making those changes. Now, you can argue that there was some technology and health, whatever, progress in the same amount of time, but that's a huge difference. Not only that, hospital networks only nationally, when you do the research, only affected perinatal mortality. That was it. Didn't improve mortality for anybody else. People with cancer, people with heart disease, anything else. And you're shocked, right? You go, well, when I have my heart attack, I want to go have my quadruple bypass. And when my kidneys fail, I want to go have dialysis. And when I'm in a car accident, I want to be in the ICU. And to some degree, all of that is true. But when you balance your checkbook or your bank account at the end of every month, we as Americans are going to have to think this one through. And it's going to be this coming generation that's really going to have to deal with this. So I'm learning stuff, right, through all of this. So now the health plans and formularies issue. So this is just quantifying what I said before, which is how much money are we actually spending. So Portugal made this system to national coverage. In the US, how much are we actually spending by avoiding national coverage? And I mean single payer, right? Because right now I have to do as much or more health insurance documentation than I did before the ACA or anything else. That hasn't changed, unfortunately. It does mean more people have access to care. So 48.5 hours per week per primary care physician on health insurance paperwork. $70,000 a year equivalent. So and then in 2016, there was a new study that showed that primary care practitioners also spend another $50,000 a year on quality reporting, right? So we're going to have high value care, right? It just makes me choke to think about it. So thus, $120,000 per primary care doctor. What if we saved that, right, by not doing these two things? We could pay tuition for 2 medical students per year, pay health premiums for 5 families, allow PCPs to see 10 more patients a week when they weren't filling out that paperwork, and increase primary care incomes by $52,000 a year. And the gaps between primary care doctors and super specialists' incomes, by the way, are a couple $100,000 at least. So nobody wants to go into primary care. Well, duh. You have to do all this paperwork, and you don't get paid well, and you've got this huge debt. I mean, it's a challenge. So, in summary, this is my pain scale. In Australia, I think it was a 1 to 2, right? I haven't practiced in Norway or the Netherlands where it's supposed to be really slick, right? But in Canada, we still had to deal with formularies, direct-to-consumer advertising. We had to deal with billing. So every time I would attend in the hospital for 2 weeks, it would take me about a day to do all my billing. And then in the US, oh my goodness. Yeah, well, you get the picture. So if I were queen for a day, before I got beheaded, I would, 1, create an international registration system of competency-based training equivalency. In all my travels, I think the US, Canada, Australia, New Zealand, at least, basically have comparable training. And from taking all their exams and stuff and teaching there, I think they're pretty darn similar. And if I were me, I wouldn't waste time having people sit out for a year while they get re-credentialed and tested and everything else. We should probably have some peer-to-peer supervised practice things, but we're really wasting a lot of time, money, and trained health professional experience. I would make the VA system national in the US. The taxpayers have already paid for it. You may not know this, but the VA is the world's expert in healthcare services research. They have been able to show better outcomes, more healthcare improvements, and all that stuff. Yeah, it's a big bureaucratic system, but it's not anything compared to all the private payer stuff. I would change the salary structure for primary care to reflect cost effectiveness. There's a woman named Barbara Starfield at Hopkins who did a study showing that 1 primary care provider per 10,000 people results in a death reduction of 14.4 deaths. So what we can do through WSU, through this new medical school, even if only half of our people end up being primary care docs, that would be 70 deaths from our first class, right? That we could prevent. So, and then I think the US has internal medicine wrong. I think we should be working more in teams where we try to get everybody working to the top of their license. And again, this is an opportunity for this community to actually do some research on how close can we get to that. We have a big hope that we will be able to make some progress in being leaders in interprofessional care. And I think this is a big question where people have been trying to show this, but they haven't really been able to manage it here. But I think it's something we should look. So research in our future opportunity knocks. And I won't take time on this because I know people probably want to ask questions. But this is another example of my opportunistic research. When I got to Australia, we had to show that millions of dollars of funding that were going into these new rural initiatives and new rural schools, like WSU in some respects, were actually producing outcomes. So I am the grandmother of the medical school outcomes database in Australia, which is still running. We started with the back of a napkin coffee meeting with 4 of us. I actually wrote the first paper in the car as we were traveling to a meeting I had 2 hours in the car with 2 men in the car to help write this paper. And then we went to the government and said, look, we need to get this funded because we want to be able to show you that we're making a difference. And we did. And the rest is history. And some of the other stuff that happened that we're going to try to do here at WSU. So now that we're in competency-based medical education, think of surgeons. They have to log all their procedures, right? You don't want a surgeon to do your appendectomy who has done 1. You want somebody who's done 50, right? Or however many it takes to be really good. But there's a curve for basically every surgery that we know, for example. So we developed a program, and I was pretty dumb about this because I had a business manager and we were trying to do some innovation, develop the programming. We had the idea. We hired a programmer to do this, and we didn't get the contract quite right, and basically he walked off with all of our IP. But in the meantime, we made an interesting discovery. We decided to not only track what they were doing, but because we were in a health professions workforce shortage area, we had nurses teaching, we had people who didn't speak English, who were residents from other countries teaching. We said, okay, well, what's the quality of this teaching across rural Australia in a state of about 4 million people? And the interesting thing was, We found out that they were seeing enough cases, they were getting good training in rural settings, they were basically seeing more stuff than the city-based students were seeing with all the Nobel Prize winners and all the subspecialists. But we also discovered that they thought their learning with consultants, so read attending or senior doctors there, was the highest, but all other encounters were very good and basically not different from training with a consultant, including nurse-led instruction for doctors in nurses' area of expertise, and peer teaching, which also surprised us. And they also were good independent learners by the time they were in their final 2 years of medical school. So that gave me a lot of freedom and confidence to be able to say, we can do this in a rural or regional area without Nobel Prize winners and with an interprofessional team. Thank you.